Can you all see the agenda? Okay, so we're going to start by talking a little bit about the role of the supervisor of a CHW. Let's have a conversation and try to understand better that role. And then we're going to share with you several resources that will be great to perform this task. And for some of you that are working with us in other grants, these materials will be presented to other members. These are just recently created, so we really hope that you can benefit from them all. With us today, I want to introduce Mary Hunt Moore, our new grants manager at TCCN. So say hi, Mary. Another Mary in the team. So Mary started with us on Monday, and she pretty soon will be taking on all the roles for compliance and the many documents that we will need to be working on for each one of the grants. We also have Dr. Vicki Burton. She will be presenting the first half of the meeting.
Sorry, I'm going.
And she is, as you already knew her previously, she works for Rural Health Association of Tennessee, and we're working in connection with them. And also today, we're going to be joined by Tariq Smith, our program evaluator, and he works for Meharry, but he works also with us as a consultant, and he will be presenting the general policies. And he have great input about the data collection tools that we develop and how to implement them. So that part is going to be also joined. So let's see if Dr. Burton it's with us right now. Yes, so she can start with her presentation. Dr. Burton, are you there? She is okay. She is here, but she has not been able to share.
She was just on video. Maybe.
Good morning.
Good morning. How are you? How are you feeling?
Well, I thought I was feeling better and tried to go back to work, but not quite there yet.
Oh.
So, but hopefully I'll be getting there soon.
Yeah, we pray for that.
Well, thank you.
So we're waiting to see if Dr. Burton can join us.
Yeah,
Okay,
again,
great.
she got disconnected.
Yeah, I think she left, but we'll come back on. We saw her on video, so.
Yeah, I had a little trouble getting in as well. Not sure.
Yeah, for those that do not use Microsoft as their platform, it's good that you actually download the Teams app in your computer, and that will allow the presentation to run better.
Annabelle, while we're waiting for Dr. Burton, I could just do a little bit more of an intro on rural health and some of what we're doing.
Perfect. Let's do that while she can join us.
Okay, sure. Well, I'm JC Worrell. I'm Executive Director, Rural Health Association of Tennessee. I feel like we've been on several calls with you all now, so you've probably heard a lot of what we're doing. But just to kind of give you an overview, I don't know if we've really talked about who we are and what we're doing. So we are an association. We've got 600 members, and our members are very diverse in professions. We've got school health people, hospitals, charitable clinics. Miss Sarah Wells on this call is on our board, and and FQs and a lot increasingly mental and behavioral health providers. And as a partner on this grant, so you all have heard about the apprenticeship piece and the community health worker piece. We're developing some training around this, and we've got Dr. Burton, who is now on. So I will hush in just a second. But just to let you all know some of the other things that we've got kind of in the works now that we finally have our fully executed contract. We budgeted some funds for professional development stipends for new professionals in clinical or community health worker behavioral health settings. So that's kind of a piece that we haven't even started talking about. And really, I think the common thread in everything that we're doing is strengthening the workforce, the healthcare workforce, addressing those health professional shortage areas and helping with recruitment as well as retention. So we know recruitment is a challenge. We don't talk a lot about retention, what happens when people get employed, but they incur new expenses or they don't have the training and supports. And of course, we're all running, so fast that it's hard to take the time to slow down and really give people that mentorship that they need. So I think that's really the common thread in everything that we're doing, is trying to support people with the idea that the more that they are developed and the more training and mentorship and supports that they received, the longer they're going to stay in their positions, A, but B, the more likely they are to try to continue up that healthcare ladder. So that's really the goal of what we're trying to do. I see Dr. Vicky, poor thing. I think she got bumped off again. If anyone, let's see, here she comes back. Hi, Dr. Burton.
She's having trouble hearing us.
Oh, okay.
Mm-hmm.
Which is weird because we use Teams, so I don't know what the issue would be. You know what? Let me send her a message. She may just need to call in on her phone because we can see her. I'm gonna mute myself actually and just.
And we can go ahead and turn it around too. Annabelle, you want to just start with policies while they get that together out of respect?
Yes, sorry, that's exactly what I was thinking.
Let's go ahead and shift the order. Yeah, out of respect.
While she,
time.
Yeah, while she can figure out what's going on, let's continue. What we can do, let's switch. So I'm going to start our part. Dr. Burton, can you hear us? No. So let me introduce you quickly to the tools that we have developed. Well, I was talking to some of you discussing the budget, and also previously in our last meeting, there were some, we tried to contact immediately the Tennessee Department of Health, trying to get clarification of the reporting that will be needed for the Community Health Workers Grant. We have not received the final format for their data collection requirement, although based on what is in the contract, we went ahead and created reporting format in a tool called JotForm. And we talk about that in our previous meeting. And we show you guys, or Felicia introduced the JotForm. We are going to, right after this meeting, send you a quick guide of everything she discussed in the presentation, so you guys can have that like in a one-pager for easy refresh. And we created new forms, something easier for you guys to have during the event to collect data and, then to summarize the information from the different events. So when you guys sit down to work with JotForm, then you have everything in one page. So that I create everything in Excel. So let me show you this, and please let me know if you guys can see this form. It's a sign-in sheet. We, everything will be in one document, in an Excel document, because it could help us collect the information easier. Although even when this is an Excel document, it was prepared in a way that when you try to print, it's easy to print and it will be easy to have. You can print this one multiple times because for every event you could have this. Now, our document, sorry, will have three tabs. The first one is the sign-in sheet for the event, and that is to be completed by the participants. And we're going to take a look at each one of them. If you have your own sign-in sheet, that's not a problem. But some of you, when we were having the conversations about the budget, we're asking, can you guys help us develop one? So we have this tool for you all. There is another form that we will see in a minute that it's to collect demographics. This one will be completed by the CHW. In conversations with Tariq and understanding better at the type of clients and the people that will participate in our events, we know that asking them demographics may be a touchy subject and they could feel a little bit intimidated in providing that information for many things that we even discussed in our last meeting. So the way we're going to collect demographics is going to be really simple. You will see in a minute. And that document will also have a tab for the summary. That's where you can collect all the information for all the events for that month. You keep that in that summary. And with that summary in hand, it will be very easy for you to just enter the information in jot form. So let's take a look at the forms per se. And then our part will be quick. Dr. Burton, whenever you're ready, you let me know. So this is the sign-in sheet. And as I said, don't get intimidated by the fact that it's Excel, because when you print it out, there's nothing here that says that it's Excel. Okay. This one, we want to know if the event has a name, sometimes it's like a fair or, health fair or an event at your organization. If it has an event, then let's put it right here. But if it does not, then we just need the date and time. Even the location, just to know if that was in your facility. You don't have to put the full address. It could be, you can just say clinic or where exactly it took place if it's outside the clinic. And you can ask your members just to put their name, whatever they feel comfortable with. It could be their initials, their name, their full name. Now, we know that in many of these events, and that was in conversations with all of you, in many of these events, the adults bring their kids, especially if there's going to be after work hours or during the weekends. So we don't need to collect data about the kids, just the adults that will be participating there. And remember that if we're talking about 5 or 10 or 20, it doesn't matter. It's an outreach event that you guys are conducting. If that's in conjunction with other people, it doesn't matter. Try to ask people to sign your sign-in sheet so we can count those participants as part of the grant goals. This document, once completed, it will be great if you can scan it. And this is a document that you can upload in jot form to show that the event took place. This is part of the compliance piece that we all want to make sure that we can do. Now this again, you just put it maybe in the registration table. People can sign in. You make sure that every adult there have signed in the way they want, right? But at least it gave us a better idea of how many people showed up for the event. Now, if we take a look at the tab that is called demographics. Okay, there's a lot of demographics here. Don't be scared. Again, on the top part is everything about the event. And what we want to do, in addition to knowing basically the location, will be which county this event took place. It's very important, and every time we have to complete a report for TDH, they want to know if we are serving any of the counties that are considered at risk or distress. This is going to help us capture additional information for new grants that may be in the pipeline. And now that Mary Moore has joined us, we know that there's other possibilities out there that we can start looking for, but sometimes it's difficult for us to pinpoint which counties are we really serving, thanks to you guys. So we're going to start collecting a little bit of information about the county where that event took place. In here, again, don't be intimidated. We don't need numbers. The good thing with this, we just need to know if this age group, even if you have one person, put a, check mark on it. Because when we have to complete the report to TDH, they're not asking us for how many people with, 30 years old. No, they just want to know which groups we were present in our events. So if there's females or there's male, just check marks, no numbers. Very simple. We are not going to ask you for something that is going to be, a headache. Ethnicity, if they are Hispanic or Latino or non-Hispanic or Latino, very simple. The race, again, no numbers, just mark everything, that you can just glance. Okay, we have these groups represented. Let me clarify here, and we're using the language that they are using for the disparities grant. American Indian is the same as Native American. I don't know what they're using American Indian, but that's how they're using it. But those are Native Americans. And we have Asian and then Native Hawaiian or Pacific Islander. I have no idea if we serve those populations, if we have people going to those events, but it doesn't matter. Just check marks, no numbers, okay? So this is something that when the event is taking place in a moment, the community health worker could just glance at the audience, make the check marks, and save that document. That way, we're not asking anyone for their age or their race, so people should not feel intimidated by, we getting into their personal information. This document also, just with check marks and the top part completed by your community health worker, will be also uploaded in jot form at the end of the month, or you can, every time you have an event, you can start adding information. The system will allow you to do that. Again, just check marks. Then the summary, which could be completed either by the community health worker itself or by the supervisor when checking all the paperwork that is going to be uploaded in jot form. It depends on how you guys distribute that particular task. We can have, you see that we have one column for each one of the events. At this time, all we need, let me put here clinic, is the clinic name and what month you're reporting, okay? And I know that some of you already have nice information for February, so you guys can add that information here. In this case, this is not going to be uploaded in jot form. This is really to facilitate you collecting all the information from the different forms, and that way you can sit down and just start entering information in jot form. So this summary will not be uploaded, remember. Now, the number of participants here, it's really, if you have the sign-in sheet and you have until number 17, very easy, just number 17. If that event is actually to promote vaccination and it's actually an event that the vaccines are going to be provided, fine. Then if that's what you're going to report, because instead of outreach or education is about administering vaccines, then you put the numbers here. But remember that this goal is not only about that. The grant is really to outreach, education, and administration. So if you have 0 numbers, that's okay. Now, if you actually were able to have an event and that brought you people later to the clinic to get vaccination and you see an influx in vaccination, let's report that because it's the result of this event, right? And these ones are not necessarily related with one event. So it could be, what kind of, if you were able to provide rides, either through the option that we provided you with Uber or any other option, maybe a volunteer, maybe a staff member, somebody that assists this particular client with a ride, count that here. and the number of appointments coordinated to get the vaccine. Maybe you will need to modify the sign-in sheet, and people will say, well, I really want to do, after I learn something, I really want to do the vaccine, but in that event, you do not have the vaccine. That's not a problem. Just make sure that you can collect information from this individual completely voluntary, so you can schedule an appointment with them later, or that you can follow up and provide information on how to get the vaccine. So these documents, we're going to send those to you at the end of the meeting. And if you have any suggestions or questions, we will make the appropriate adjustments. But the idea for you is that if you need to modify, go ahead. You know, if you want to add more events because you know that you're having 2 events in a month, in a week, let's modify that. The idea is to help you capture that data during the month. And when the time comes for you to sit down and complete jot form, you have everything right there accessible. Now, the top of this form is for any kind of outreach event. If you have a community event that is so big that you can really not count people, then, but you have an event and you estimate, there's no other way. If you post something in your social media tools, you know, I know that there's some metrics that you can pull to find out how many people, and what is the traffic and how many people really like your message or your post. If you were on the TV, that would be cool. If you were on radio, if you were able to print something, maybe for the community newsletter, right? If you modified your website and you can calculate the number of views that took place during that month, perfect, count it there. In this case, you may need the assistance for whomever helps you handle your website. If you decide to do a banner outside or, anything that invite people to your event, then that's outdoor impressions. And finally, if you actually have a newsletter, and many of you do, sometimes monthly, quarterly, or even bi-monthly, let us know what are the number of clicks. If you want to add a comment here about, we do newsletters every other week, perfect. Add that information there so we have a better understanding of how frequent you do that. Remember, as soon as you have a piece that talks about COVID, you can count that, right? Because that's the idea, education. I am in this case, there's going to be a section in jot form specifically about this. So if you think of anything else that you guys are doing that should be in this list, let us know. Let's add it. The best good thing with jot form is that we can modify that at any time. We don't need to pay anyone to do that because Oclisha Renee knows how to do all the changes and we can update that information. Now, a newsletter, if you do like quarterly newsletters, for example, and I have a question from Lynn, I will address that in a second, Lynn. If you have a newsletter and in the newsletter it's quarterly, so it's possible that you release the newsletter and the month number 2, you still have new clicks there, counting on that particular month. But if the social media, it changes, that's when you need to count it when it happens. There's things that can only be counted one. So whatever happens in that month, let us know. So it doesn't matter if the newsletter was sent last month, but if you're still having new clicks this month, count those clicks. If you still happen to have movement in your website, count those. Let us know what is new. Now, Lynn is asking if the media impressions, if that has to be COVID related outreach or any outreach. Did I read that right? It's only COVID related outreach or any outreach. It actually, most of the concern for this grant is COVID related, but we want to capture everything. So what we could do is let's add things that could be community events, not COVID related. For now, we're going to capture everything because we do not have specific instructions from TDH. So maybe some of these things will change later. And if that's so, I sent multiple emails that I don't know. I don't have an answer. But for now, for us, it's important that we capture everything you guys are doing. But so in that case, I remember that jot form has a section for comments. So you can add any comments that we also have this number of events thanks to our community health worker that it was not COVID related. Perfect. We want to capture that.
And perhaps in that section, Annabelle, we would do directly and indirectly. So the general developmental educational materials that are like for community behavioral health events that are absolutely relevant may be classified as indirect. And then so we wouldn't have not related, we would just have directly and indirectly. And then we can count everything.
And in that case, Tariq, do you suggest that we actually have like 2 columns, like COVID and non-COVID or something like that?
Perhaps just directly and indirectly related to, because that way the comprehensive, the educational outreach and educational materials for the HEDIS, the behavioral health stuff, just all of the other kind of general health information that goes along with making healthy decisions can be captured well. So if we do end up needing to report, we'll have a direct line to report the directly related, and then the kind of indirectly related would perhaps address Lynn's question and give a place to put all the information.
Yeah, we will be then. What I'm going to do, let me get with Oclisha, let me make a tweak on jot form. And with that, we will make sure that that change is reflected not only in these forms that I just showed you, but also in the 1-pager guide that we were going to send you to make sure that everything reflects the last changes. But again, there could be more changes depending on when we hear back from TDH. But for now, I know that some of you already hired your community health worker and you want to keep running. I think that this could help you. Does anybody else think of any other change, something that you're not seeing here that you know may happen at your community? Feel free to let us know. I know that Dr. Burton has tried to connect several times. So if that's okay, we're going to continue with, remember, share your comments or questions at any time, okay? So let's talk a little bit about these amazing tools that Tariq is sharing with us. Okay, I have another question. Yes. Okay. Kelly is asking if the encounters that occur after an event, maybe next week, if we can count those encounters in the summary sheet under the original event. Yes. And let me tell you, how can we do this? I don't know if all of you do this, but it will be good when somebody shows up and you ask them, how do you know about us? Or just asking them what brings you here today. I'm pretty sure that many of you asked that. And some of them immediately say, well, I was in this event and, really this information was so good that I decided to get vaccinated. Cool. Let's find a way of you capturing that, because it's evidently a great result from your outreach event. And let's do that. Let's capture that. And that's another thing that I can discuss later with Tariq and Mary more, how we can make the distinction that that was the result of the event in our data collection tool, and that will be included in the new version, okay? Any other questions or comments? This is really good. This is so Tariq is sharing with us, when we started the conversation with Dr. Vicky Burton and we were talking about the different topics, and she shared with us what is going to be the curriculum for the community health worker. We were thinking, okay, there are some important policies that we could put together and that we can share with you guys, especially because I know that all of you have been doing outreach or education, but some of the community health workers could be going out in the community that they may not know very well, or that they may be having access, even in an event, with confidential information from the patient. So how to address that? So Tariq put together immediately 3 documents, and it's called, he called it general policies, and we're going to share those with you. Those policies include a portion about safety, a portion about confidentiality, and also reporting abuse. Some of you may be already familiar with this, but we thought this could be really helpful. He created one document with the 3 policies. You can cut and paste and modify as needed. You can separate that. And I know that in the trainings that Dr. Burton plans to provide the community health workers, there will be additional conversations about that. So it's possible that this, that is right now just general policies, could continue growing. So um, the document is very easy, great guidelines that Tariq shared with us, but I'm going to let Tariq talk a little bit more about the importance and the need of these policies.
Well, I think we'll just kind of jump right in, but these are just general, everyone, all of your clinics, all of you all have general policies that you are already absolutely adhering with, that are following state and local and federal policies, depending on your grants and funding that you're following. So it's good to have kind of a general swoop for everybody that's all involved, TCCN in general, and all of our project partners, contractors, subawardees and such, so that we're all on the same page just about general procedural protocol for confidentiality. So this is something that we will, and of course, CHW safety. I know this is a lot of your first times supervising CHWs, and CHWs do have a footprint in the community. So they're out there in the streets, they're with the people, and they are empowered to make some critical decisions in real time. So it's just important for us to do due diligence and make sure we're covering our policies, make sure we're reviewing safety protocols. And as supervisors, you will, of course, be reviewing safety protocols regularly with your CHWs. But these are kind of cookie cutters. So what we hope is that you will be able to kind of fill in the blanks. There are some insert organization names here where you can fill in your individual organization names and send them back to Annabelle, and then we will consider ourselves kind of all on the same page. And this will, as Annabelle said, be continuing education moving forward as we grow and learn. So this is intended just to be kind of a general overview to follow up and kind of just hit on general community health worker points. So would you mind reading the first paragraph for us, Annabelle?
We start here with the CHW safety, mostly for home visits or community contacts.
That's good.
And it includes information about verbal de-escalation and safety guidelines. We have the benefit of taking a look at the nice curriculum that had put together for community health workers. We know that some of these topics are going to be discussed there, but we are also planning, thanks to our partners, to provide to all our members specific techniques about verbal de-escalation, safety guidelines, and all that. So with the help from Tariq and other partners, we're putting together an entire year of trainings for everyone that has grants, but also for all our members. We think that these are great tools to have. So he, of course, go ahead, Tariq.
No, I think we should just do one with them. Let's just do, can we just do one?
Yes, we have several comments here saying that they really needed this. So this is so good that, we hit exactly what was needed. And it's, if many of you requested the job descriptions, and the job descriptions that I sent were not particular for this grant, they are really job descriptions that either from other states. Depending on the setting, some of the community health workers will be doing home visits. We don't know if that's going to happen with us, but we noticed that, and Tariq has plenty of experience working with health ambassadors and community health workers at large. If that's so, the home visit per se requires some safety guidelines that we cannot overlook. They need to know what kind of community they need to prepare. They need to do an assessment. So these are some points, the initial points. Just make sure that you have reliable transportation, that you're dressing appropriately, that you have your phone and the phone is fully charged, because if in case of any emergency, you need to have your phone with you. Let your supervisor know where you are. So these are basic guidelines, okay? But we're not going to assume that, common sense is sometimes is no longer common. Not everyone thinks exactly the same way. So we think that this is going to help. Okay. So, these are basic things, safety awareness. How do you scan the environment to determine if there's any kind of safety concerns? And also, basic body language that may indicate that something is happening. Okay, let's be clear that the intention is not to make you an expert, that you can go and work with the FBI. That's not the intention, but it's to give you some guidelines and how to observe and how to learn, okay? So the first one is about safety. But of course, if something happens, we have to report those incidents. The purpose of the incident is not to get anyone in trouble. It's appropriate record keeping for your clinic of the things that are happening, maybe in one particular community or maybe in one particular environment, that could help you train your staff better, add additional safety guidelines, or even just lessons learned on how things should be addressed. And this is something that is part of the coaching that JC was talking about, and is part of the feedback that the supervisor could provide that community health worker later, because the supervisor was not there. And, when you get a description of what happened, you may think, well, you could have done X, and that's a great coaching opportunity. But there are some incidents that, yes, you have to call the police. So we can also assist you developing incident report forms. I know that most of the clinics have their own, and that could maybe be tweaked for visits instead of incidents at the clinic, okay? The second document is here and is reporting um, um, suspected abuse or neglect. And this
Let's
is,
just go bullet for bullet on this one, Annabelle. Can you just run it straight down and kind of compliment? Because I want to make sure that we touch directly on a couple of these bullets. I want to sweep past it. I want to make sure we actually hit a couple of these. But can you hit the major bullets for me so I can chime in?
for the
And
suspect.
it may help them to do the general, the first part of the first one too, because that kind of just says who community. I know they haven't really heard of who community health workers are yet, and like I know that's what Vicky was going to do up on the front end, but we may want to just kind of run back through. It's built to run just straight on through them. So if we can just kind of tap 1, 2, 3, 4 and kind of skim through as we go, they can ask questions as we move and actually fill in the blanks as a working document.
Okay, and JC has the slide, so JC will be doing Dr. Burton's part since she still have issues, technical issues. But
Yeah,
Mhm.
yeah, I think she was just on, and we do go through a little bit of the history and things.
Okay.
And we've got the definition ready, so we can do
Okay.
some level setting.
So perfect. Then let's, you guys will provide that. Let's use the remaining 20 minutes in the rest of, but yeah, it's important to understand that the community health worker will be out there and will be constantly addressing social determinants of health. That's why they exist, essentially. So if that's okay, Tariq, since Jason has the presentation, then she will do that part. But let's go to, there's the safety, and later we can have specific sessions to talk more about these policies and techniques, and with the help of Tariq and other community partners. Reporting abuse, it's a delicate topic, but you know that we are all mandated in the state of Tennessee to report abuse if we see or detect anything. So it's important that this is one of the sections that Tariq was saying, that some places that you have to add information about your particular clinic, and there are things that here refers to TCCM, but it will be satellite locations for
No,
you
you
guys.
that's written. No, they're set. They're able to read. So the TCCC said that says that these general policies refer to all TCC and members, and in the individual section where it says where there's an asterisk, your own organizations, the individual members will fill in their organizations in that context. So it's built as kind of a working document. If you could, if you all can kind of take your time to go through it, as it won't take long to go through as an exercise, but you go through it and where the or asterisks are and the open sections are for member organizations to fill in, and it shows the cascade and the relationship between member organizations and the kind of overarching umbrella. So it touches on the different it attempts to display the relationship. So to say that these policies apply to all, and then it goes to members, volunteers, on well. So there are open sections for your own agent, and it would be helpful actually if you all could review these documents, fill in the blanks, and then return those to Annabelle, so we have a kind of running document. And of course, all policies should be reviewed with your own organizational policies and adapted as you see fit.
And I want to point out, as Tariq added here, the purpose is to, outline the response to suspected abuse of a child, an elderly person, or a disabled person. It's not only about kids, it's all of those we're required to report. And there's other places, like Tariq mentioned, that it says that the policy shall be reviewed by your quality assurance officer. You can change that with the appropriate title of the person within your organization that reviews policies or approve them. Everywhere here where you see insert your organization, you can change the name of your organization. And the procedures are listed here, but let's remember each situation is different, and there could be times that you may need to ask someone first to see, okay, what should I do here? But it always need to be not only shared internally to make a discussion of it, but it also, you need to follow the basic guidelines that usually the staff needs to discuss with the supervisor, and then follow the agency protocol as well as the state's protocol. So I know that we are running out of time, but I'm just trying to highlight the basic things. Remember that things like that should also be documented. So if you have an incident report form, please keep that. Try to keep that information. And when you guys, if the phone call was made to any of the hotlines from the state, when the phone call was made, and try to document that information. So the third policy here, and again, anyone that has questions, we can review this more in detail later. It's about confidentiality. It's, basic information that, even when we're, some of the clinics do not collect HIPAA related information. At some point, they will all be privy of some sort of detail from the family, some sort of personal identifiable information for that individual. All that falls under confidentiality, and we need to make sure that it includes the records, it includes communications. It also talks about the medical treatment, but there could be other, I'm making the change here quickly. It could be other information that they could have access to, even their immigration status, or, if they have previous records or things like that. We're not going to disclose any of that. And when the community is small, we could be, things could happen that people start talking. We need to make sure that we provide appropriate treatment to this kind of information. So there's some guidelines here, and it specifies in the scope, like Tariq mentioned earlier, this applies to all employees, contractors, vendors, members, even volunteers. And you can have this one-page confidentiality policy that you provide your volunteers when you train them, just to make sure that everybody's in the same page. And there is a description, the most of it has to do, that we are going to respect the privacy and confidentiality at all times. And the procedure, that is going to be observed mostly by the clinic in how to make sure that this confidentiality statement is, shared with everybody that needs to know it, employees, volunteers, supervisors. Then in the case of a contractor or a regulator, we make sure that they have access to medical records. They have access to some records, but even taking pictures, we have to be careful because the picture, sometimes you need consent from the client to take pictures. If they're minors, usually we don't show their faces, things like that. Pardon?
You always need consent, by the way, and not sometimes. It's always at community events. This is an important point to review with CHWs, because they have community events. A lot of times people have videos and are making copies of what's happening. And community health workers typically closely reflect the population served. So a lot of times they are paraprofessionals. They're already involved in the churches and the communities and they're embedded in what's going on. So it's really important that they have an understanding of confidentiality and the protocols for protecting confidentiality with any type of identifiable images or anything. So it's something that you need to review regularly with your CHWs.
Yeah. And I think that's usually included in a notification of client rights that many of your clinics has, where people, know about their rights and how to file a complaint if they have to, or a grievance when something is not appropriate. So everything it's here. Information about where to keep the medical record is something that many of you already have a policy about it, but it's just a reminder of the basic conditions on how to handle a medical record. What are the exceptions, for example, subpoenas or court orders. But remember that what we were talking about is not only about the medical record, but also just client information that could be obtained even at home. Okay, so what kind of information you can leave in a voicemail. All those details are here. And it would be great that, later we can add more by having additional conversations with you all and see what other needs do you have with general policies, or a revision of your existing policy about that. We can also do that. Terry, do we have anything else so we can pass the baton to Dr. Burton?
No, ma'am. Pass it on.
So remember that you can send us an email and let us know at any time if you need help with these or other policies or procedures, or creating forms if you need to. In the email, I ask that if that's possible, that you can share with us in an email those that I have already hired the community health worker. What is their name and when is it that the starting date? And whenever you are able to hire your new community health worker, we would like to know when he's hired, because that's part of the report that we need to complete, how everybody's doing with the grant. So I'm going to pass the baton to Dr. Burton so she can continue, or JC, with the presentation.
Okay. Good morning. Can you all hear me? Okay, we're going to go ahead and get started. I'm going to populate this PowerPoint presentation. Hopefully this computer will be working. Let's see.
And while she's doing that, I'll just share, Dr. Burton, I think we got it, but I kind of gave the overview of the organization already. So we've got that piece. And then For everybody else too, I didn't mention that we actually have a community health worker advisory that's helping work through some resources and some things as well. So we are continuing to evolve the training, and Dr. Burton is a master facilitator. So when she works with your community health workers, she will, it'll be engaging the way a true training would be. And I know we kind of got off balance this morning.
Okay.
And Dr. Burton, if you don't have your slides, I can pull them up in advance for you because we're still not seeing them here.
Okay, okay, let me try this here. Maybe let me try this and see if this is going to do it. Are you able to see the screen now?
Not yet.
No. Okay. I'm letting you
I'll
help
go
me.
ahead and share
Okay.
mine.
Okay, great. Thanks, JC.
No problem.
Okay.
So, like I said, so we've kind of already gone through. I'll just start, the agenda. I think we're going to kind of skip on into the community health worker benchmarks.
Okay. Sounds great.
And then you just tell me when you want me to advance the slide.
Great. Okay. And again, welcome everyone to the Community Health Worker Supervisor Training 101. This is a pilot. I do apologize for the technical difficulties, which was something beyond my control. But again, it is my pleasure to be able to have a dialogue with you for about the next hour so that we can share a collective expertise in terms of helping to ensure that our CHWs receive the training, the technical assistance, and other areas of knowledge that is required for the position. Through research as far back as 1950 to 1960, what we're going to look at is a landscape as it relates to community health workers. And this was certainly a learning experience for me. Most of you may be familiar with these benchmarks, but around 1950 to 1960, in China, there were community health workers working in their communities. There were healthcare providers providing services. However, because these healthcare providers went from providing healthcare services back to their farming responsibilities, they were still seen in a peer-to-peer capacity among the communities. And therefore, it ended up being the implementation of what's called the Chinese Barefoot Doctor Program. In 1970, the community health workers had a rallying voice within APHA, which is the American Public Health Administration. And from that, they formed what's called the Special Primary Interest Group. In 1980, we have MHP Salute, and that was a collaboration of various entities, groups, volunteers, etc. They came into existence in 1980. In 1998, we had the National Community Health Advisor Study. In 2000, SPIG changed its name to the Community Health Worker Section. 2007, Health Resources and Services Administration National Workforce Study. 2010, we had the U.S. Bureau of Labor Statistics, who assigned an occupational code for community health workers. In 2010, we're familiar with the Patient Protection and Affordable Care Act. And then in 2013, we have the Centers for Medicare and Medicaid Services, who put some new ruling around reimbursement as it relates to community health workers in various states. Next slide, please. Also in 2013, some states took the initiative to advance the CHW infrastructure, professional identity, workforce development, and financing. So again, the field for CHWs continued to expand. In 2014, we had the CDC Policy Evidence Assessment Report, and that was on policy components as it relates to community health workers. In 2014, the Bureau of Labor Statistics reported that there was roughly around 115,700 hired health educators, as well as community health workers. And then in 2016, there was a total of 16 states that had reported having community health workers standard operating procedures or certification laws in place. And of course, I have my source listed there. As Tennesseans, we're familiar with the 2016 Tennessee Meharry Alliance that was formed. And because of the work and the need for community health workers, according to the U.S. Bureau of Labor Statistics, community health workers are likely to increase 17% from 2020 to the year 2030. Next slide, please. This definition for community health workers was adapted by the Community Health Worker Collaborative of Tennessee. And it reads, community health workers assist individuals and communities to adopt positive behaviors and conduct outreach to implement programs in the community that promote, maintain, and improve well-being. These trusted individuals provide information on available resources, provide social support and informal counseling, advocate for individuals and community needs, and provide basic services. Community health workers are individuals from local communities who, because of shared experiences and established relationships, can see and sometimes act on social issues that are invisible to others, enabling them to serve as liaisons, links, and intermediaries between health and social services and the community. They may work in clinics, community agencies, schools, and other settings. And this collaborative worked for a couple of years on the initiative. And as an association, this is the definition that we have adapted for community health workers. Next slide. The objectives that we're going to talk about for community health worker supervisors. Number one, we're going to look and see how we can enhance the supervisor's understanding of community health workers' role. We will discuss some supervisory best practices, and then we will secure some resources for the supervisor's toolkit. Next slide. CHW's some key roles, scope of practice, and outcomes are as follows. We know that community health workers perform a number of services. We have some of those listed: health advocate, peer counselor, patient navigator, outreach worker, community health representative, family support worker, family advocate, and there are more. Community health workers have shared life experiences. They live in the same communities and build trust with their clientele. Community health workers work in a myriad of settings and in different disciplines, and the scope of practice determines the capacity in which they work, be it a hospital, rural clinics, schools, managed care organization, mental health and substance abuse providers, public housing, etc. Outcomes includes bridging the clinical and community connections, addressing both medical care needs and social determinants of health, improve access to and use of healthcare services, improve adherence to healthcare provider recommendation, and reduce utilization of emergency and specialty services. And we do know that there are some other benefits and outcomes, but we just wanted to share a synopsis for the point of the pilot presentation, just so that we could all be on the same page as it relates to the role, scopes of practice, and outcomes. Some core competencies. Core competencies are the essential skills, knowledge, and abilities that allow CHWs to perform their roles and or tasks. And some competencies that we're looking at are communication skills, interpersonal and relationship building skills, service coordination and navigation skills, capacity building skills, advocacy skills, education and facilitation skills, individual and community assessment skills, outreach skills, professional skills and conduct, evaluation and research skills, and then we also have knowledge base. So these are some core competencies that we will be looking at in terms of ensuring that our community health workers meet those areas to better perform their job in their roles and scope of practice. The apprenticeship program reminders. As we're looking at this, I'm going to allow my colleague, Patty Lane, who is the expert with the apprenticeship program. She is the workforce development director. She's going to share some additional information as it relates to this. But the apprenticeship program, as it relates to the CHWs, one-year program, it requires 144 hours of related technical instruction. And once 1,000 hours have been added onto that, there will be a certificate of completion. The community health workers training will be free if the employer agrees to sign up and become a registered apprenticeship. Rural Health Association of Tennessee will be providing the training materials. And then at this point, Patty Lane, director, is going to share with us from her program in terms of more specificities as it relates to the apprenticeship program. So Patty, will let you share at this time.
Hi, Dr. Burton, and greetings all. It's good to see you this morning. I know I've already connected with a couple of you individually, so I won't go into great detail about what an apprenticeship is. I think you've received some slides that kind of gives the benefits to both the employer and the apprentice. What I would love to do is just set up a one-on-one with you, just send me some available dates and times that would work with your calendar, and we can kind of go through the forms that are available, which isn't many. Lynn, I think, who is on this call, can tell you it's a very easy process. I met with her and her potential community health worker and explained the process. She got the forms back to me in record time, and I've already set up regular meetings with her community health worker or potential community health worker. So as JC mentioned in the very beginning, part of our workforce initiative is to help recruit and retain. And so we're hoping through this kind of supportive services and case management that employee will really be excited about continuing their relationship with their employer. And so rather, you've received already a wealth of information this morning. So I think it takes a few times to hear, what is an apprenticeship? And so this is one that we have, that Rural Health has adopted. We think you'll be thrilled with, and doesn't take a lot to get up and running. So I will put my email in the chat box, and just when your schedule allows and you've digested a lot of this information, just send me some available dates and times, and we'll connect and be ready to roll. So good luck with the rest of the training. Thanks for the time, Dr. Burton.
Thank you, Patty. We appreciate you. Okay. Next slide, please. What we have in front of us now is you'll see the word draft written across this document, because again, this is a pilot, and we appreciate everyone for being on here to share with us and give us any feedback that you see that would enhance future training for supervisors. But this is the training calendar for the community health workers that we will be utilizing. And basically, we will have week 1, for example, the rollout for that particular pilot for the community health workers training is going to be on April the 11th. From 9 to 10, the topic that we will cover is the role of community health workers. And as you see, that's a 1-hour session. The following week, there will be a core assignment for the community health workers based on the prior week's discussion, our class discussion. The next week, of week 3, we will go with the next topic. And as you can see, it's the evolution of community health worker field in the United States, the shoulders we stand on. And we actually have a calendar mapped out all the way through 2023. And again, the topics that we have coincide with the core competencies. And the core competencies that we're following are from the C3 project, which was implemented and instituted from the University of Texas. In this project, community health workers across the country were brought to the table. These core competencies are evidence-based. Add-ons in 3 particular areas have been added to the core competence since the 1978 initiative. 13 nationwide agencies, including the CDC, has endorsed these core competencies. And these core competencies also align with the apprenticeship program in terms of what training is required. So again, we are utilizing a textbook that is evidence-based that's currently used at a community college in San Francisco. It's actually utilized in their certified training curriculum. And again, as you can see on this particular slide, again, it's just a continuation of the 1 hour virtual until we come out of the pandemic. And then there's an hour of on the job core assignments as well. So what we've done is there's hours that we have allotted for the week online, a week of core assignments, and then the community health workers will also get 96 hours of on-the-job learning, and that can come through specialty areas, be it the suicide network, be it through uh, an HIV advocate program. That we are allowing some flexibility, because when it comes to the specialty areas, as supervisors, you know the specificity in terms of the training that your particular community health worker will need. So again, there is some flexibility in that, but the 96 hours plus the hours that we are doing throughout the 48 weeks comes to 144 hours. So once the community health worker has ascertained the 144 hours as it relates to related technical instruction and 1,000 hours on the job, they will be eligible to receive a certificate of completion. And I know that's a mouthful, but we'll open up for questions and answers shortly. Some supervisor best practices. We want to look at administrative supervision, which deals with the onboarding, new employee orientation, time and attendance. And I think Annabelle may have covered some administrative responsibilities early on, but these are tasks and responsibilities that the supervisor generally cover with new employees, like within the first week or 2 weeks in terms of new employee orientation. You also have clinical supervision that some people may look as educational supervision, but with that, you are looking at file case reviews. As supervisors, you are imparting expert knowledge. You are observing the techniques in terms of the services or the task that the community health worker is performing. You're giving feedback, ensuring that everybody's biases is in check. Ethical issues, boundaries, and then of course, I know I heard Annabelle earlier talk about reporting data. So there are some key performance indicators depending on what the community health worker's role is that you'll be covering with the community health worker as well. When we look at supportive supervision, which is an area that is being embraced more and more, in the work arena, you're looking at open two-way communication, which consists of the supervisor being a coach, being a mentor. You're looking at opportunities that actually will enhance the community health workers' job performance by removing any unnecessary work barriers that may be present. And we know that in some positions, there could be a lot of red tape. But again, if there are unnecessary barriers, then as supervisors, we want to remove those so that we can empower and promote the community health worker to be successful in their role. Certainly, clear expectations is paramount. And we know that when it comes to SMART goals and or the job, the job description, it is imperative that those expectations are clear so that the community health worker will know what is expected of him and or her to perform their tasks, to perform their responsibilities, because as supervisors, it's imperative that they do know so they'll have the information correct going forward. It also addresses professional development. How can we enhance that person's role? How can we enhance their performance? What tools can we give them to make them better in their particular role? So that's something else is under the category of supportive supervision. Also increasing employee motivation. Though that's another area in terms of supportive supervision. When there is that two-way communication, there is constant dialogue so that when opportunities present itself, the employee can certainly know that as supervisors, you have an open door policy. They can come in and discuss and talk about their work performance. And again, just an opportunity to enhance and motivate them to continue to doing a great job. Promoting a work environment that increases job performance. Again, just having an open door policy, have an environment where community health workers aren't afraid to report something that has happened. And when the environment is such, then employees are more prone to open up because they know that whatever the issue is, the supervisor will be there to assist, address, and or help with the correction of whatever that is. And we're going to look at an exercise surrounding this particular area also. And then performance management is really critical. When employees are hired, they really should be given a job plan, because without a job plan, they can be informed of what they need to do, but technically they need to see it in writing. They need to sign off on a document that acknowledges that the supervisor did meet with the employee. We talked about these things. These are the expectations. These are the metrics that we're going to utilize to gauge and or evaluate performance. So that is critical. And then just a couple of other reminders, being cognizant of our own strengths and weaknesses, and self-awareness is crucial in any supervision, in any supervisory role that we have. It is important to meet with the community health workers on a regular basis, which would allow time for a one-on-one check-in, getting with the CHW on monthly reports for any context, context, and or performance indicators, any metrics, and to discuss other items as needed. Certainly as supervisors, we want to do that on a regular basis, would be dependent upon what you as supervisors feel that should be. Some people may see that needing to take place once a month. Some supervisors may say every other month. Some may even say weekly. Again, the number of times that you meet with your staff on a regular basis will depend upon the CHW. Is going to depend on his or her role and or responsibility. So as supervisors, you'll make that decision. And that way there is some constant communication going on, because to meet with an employee once a year, and especially if it's when they've done something wrong, again, that just doesn't set up a a warm environment that allows employees an opportunity to promote and or enhance their work capabilities. So meeting on a regular basis is crucial, and I'm sure you all are doing that now. So I know a lot of this may not be new. If it's not documented, it did not happen, and that's what a judge would say. So if you're meeting with your staff, your community health workers, certainly, write that down in your supervisory notebook that you have, and or wherever you document those types of meetings. And not only there, if a community health worker was to say, well, I went to ABC clinic, 3 times a week on a Monday from 1 to 2, and I did this, that, or the other. If there is no documentation for that, again, in a court of law, a judge always say, if it's not documented, it wasn't done. When an employee asks a question, they have actually asked the agency, because as supervisors, you're in a role to represent the agency. If the community health worker does not get an answer, then the agency has failed to follow through. And even if it's a question that a supervisor may not have an answer to, certainly, we can direct the community health worker where to get the answer or help them research the answer. But certainly, we want to ensure that when the employee comes with a question, we have effectively answered the question and met their needs at that particular time. And yes, the role of supervisor, it is a balancing act. There are some occasions where, depending on who the community health worker is, you may utilize all three of these supervision styles. And there are some additional supervision styles, but again, we just wanted to present just some initial information to you to, again, just help to impart knowledge, because a full-blown supervisory class could be a half day, it could be 8 hours, but we wanted to go ahead and provide you with some information, some resources, some tools that will help you with this particular role as supervisors. Next slide. And before we go to that, I just wanted to say that when it comes to a standard training curriculum, there is no standard curriculum per se for community health workers. Different states are developing their own curriculum based on a lot of evidence-based materials. However, the goal for Rural Health Association of Tennessee is to get on this path to certification as we adapt evidence-based curriculums specific to rural Tennessee area as it relates to Medicare, Medicaid, underserved, and the safety net population, as well as social determinants. So again, there is no set standard training, but a lot of states are in collaboration with other states trying to see what's out there, what's best, what does the evidence show, so those are some of the things that we want to just keep in mind. I want to do this exercise, and is it true or false? Looking at the first question, a supportive supervisor is concerned about the CHW's performance, safety, well-being, and professional gratification. Is that true or false? Let me see if I've got something here in the chat. True, yes. Number 2, a role of the supervisor is to be punitive when the CHWs make an error. Is that true or false? Okay, correct. That is false. we live in an imperfect world, so mistakes are going to happen. And when they do, we address those with the community health worker, find out what happened, why it happened, what can we do to help ensure that, that same error won't be repeated. But again, the answer is false. Third question. A supervisor should provide coaching and technical assistance to enable community health workers to navigate challenges that arise in their line of work. True or false? Okay, the answer is true, correct. Question number 4. Best practice indicate that meeting with community health workers one time per year is sufficient when it comes to supervision. Is that true or false? Correct. That is false, because there are so many things that can happen in the course of a day or a month, let alone a year. So great response. False. It is important for a supervisor to observe community health workers and document the accuracy and skill of service delivery. Is that true or false? Okay, the answer is true. Got that correct. It is not necessary for supervisors to conduct regular meetings with community health workers to discuss performance and issues and or challenges. Is that true or false? Right. The answer is false. It is necessary. Again, we don't need any surprises. So great. The answer is false. Okay. Next slide, please. What would you do? A community health worker who was hired 6 months ago set an appointment to meet with you, the supervisor. The community health worker informs you that the job is different than what she anticipated. She said she was excited upon onboarding and believed the health resources and services provided to the family would be well received. Nevertheless, she said the family can't seem to break from their old ways of doing things and gets upset when she asks them to try a different method or process. One of the family members became ill recently, and they said it was a CHW's fault. The community health worker shared that she is irritated, she's frustrated, she's thrown her hands in the air, and she has just told you she does not know what to do. How can we as supervisors help this community health worker? If you'll think about that for a moment and place it in the chat box.
Dr. Vicky, I
Yes.
took it off presentation just in case
Oh.
you want to have discussion. People will be
Okay,
able to
sure.
see each other's
Great.
faces a little bit more. But
Thank
let me
you
know
so-
when you want me to bring it back.
Thank you so much, JC. I appreciate that. How can we help this community health worker? And it's okay to come off mute when someone gets ready, and we can just have a dialogue around this, because we have several years of supervisory expertise on this Teams virtual platform. So I know that collectively we can share in terms of what we can do. Okay, we've got some feedback here in the chat box. It says express understanding, validate her feelings of frustration, help her brainstorm on alternate ways to talk with the family. Excellent answer. Excellent. Anyone else?
I really like that answer, but one of the questions that I have from the scenario is that she's been accused of making a family member sick. That one I'm not quite sure what to do with.
Okay. Let us ask some of our veteran colleagues in the room. How would someone answer that particular question? And while you're thinking on that, I will read another response that we have in the chat box about this scenario. Ask what the CHW thinks is the answer and help her look for answers and affirm. That's good as well. Good responses. What did she become ill with? For the sake of the scenario, it could have been a cold. It could have been, yeah, for the sake of the scenario, let's just say it was a cold. I mean, I just kind of threw that caveat in there. And I threw that in there because this is a family that the community health worker doesn't, she's not able to thoroughly engage them. They're not being able to come around because they're still thinking the same way. They're not willing to look at a different way of thinking. They're not willing to consider a different process. And in reality, I can see this seriously as being a real life situation. You know, whether it was, again, for the sake of this, a cold, whether somebody didn't, I don't know, it could have been that they may not have taken their medicine. It could have been any number of things, but just for the sake of the scenario, I'll put ill in there, but wanted to really kind of hone in on the fact that this community health worker is having some challenges trying to break through with his family.
This is Cindy Rocket. I think that was a really good question because there's no doubt in my mind that the CHWs will run into circumstances like this, possibly with some frequency. It's not going to be an easy job.
Right. And when we look in terms of the environment that we're in, we've been in this pandemic for a couple of years. So, you know, a lot of individuals are just stressed out. You know, they may be willing to blame the first person they see over whatever happens. But again, I'm really just trying to hone in and stress that this CHW is having some challenges. We have another comment in the chat box. And it says, sometimes irrational thoughts, such as the CHW made her sick, are best not directly addressed, but are probably the result of, I'm trying to scroll up to see the rest of that. The result of a deeper problem like distrust. That could very well be the case. You know, we don't know, but again, there are some challenges that this particular CHW is having with his family. We have another comment. I would tell the community health worker that people are afraid due to COVID. That's a valid response. All of these answers are good. Encourage the CHW not to get defensive by all means. Yes.
Okay, hey Vicky, let me jump in. Let me jump
Sure.
in. Rick, let me jump in really quickly just to highlight a couple of points. There are a lot of good responses, but I want to kind of highlight something and caution everybody. Community health workers are not social workers. They're not folks that are trained from somewhere and sent into unfamiliar circumstances. So more often than not, they closely reflect the communities they serve. So they live in these communities, they operate around these families, they tend to have closer relationships than we traditionally have professionally. So there's a lot of interaction that we have to be careful with, since they also reflect the clients that they serve, often in diagnosis, in social determinants, and a whole bunch of other things. Oftentimes there's some really heavy things at play. There's transference and counter-transference. There are these familiar feelings. There are the kind of projection, and there's a lot. So if you can, a supervisor should seek advice from other colleagues. If you have other folks you can kind of run it by, it would be helpful for you. But you got to be careful not to play counselor in this role. So if you have options, you can oftentimes remove the pairing process, like the pairing the community health worker with the project or with the specific services, are really, it's a important nuance within itself. But if you have the option to kind of pull them out, to rotate someone who may be better received in that context, to validate, like someone said earlier, to kind of validate the feeling, support the CHW, and kind of collaborate and make a plan together on how to best move forward. Because it's important to remember that CHWs are valuable, and the value that they bring is this familiarity. So that value is something you have to kind of translate, you have to support and endorse whenever you can. So if you keep that in mind throughout this process, I think it'll be a lot healthier for everybody involved. That's all I got.
Great comment, Tariq. I appreciate that. Others?
I also would like to add that, and it's part of the training, since the community health worker may be so familiar with the environment or with that particular client, that we may need to talk a little bit about boundaries, appropriate boundaries to, remain friendly, but also remain professional, and to also, of course, assert appropriate level of confidentiality between, for that circumstance. And as Tariq said, it's possible that at some point, part of that inability of getting deeper with that client may really hint you as a supervisor that it's best to maybe remove eventually that community health worker from that particular environment, and substitute that person by someone else, not completely from the work, but maybe from that particular circumstance, because there could be some dynamics that, it's human nature. It could be some dynamics that you cannot control.
Right. Good.
Good point, Annabelle.
Yeah.
And if boundaries is not considered a core competency, it should be.
Right. Exactly.
I like that boundaries conversation also for a lot of reasons. And I think in this situation, it's a really good scenario. Definitely more question asking of the community health worker would be helpful. Are they comfortable with that particular family? Do they have the training, the support, the resources that they feel that they need? I would be careful to pull someone out too quickly, because I don't think that's good either. It's just maybe an expectation setting with a community health worker of, we can't make people do something or be a certain way. A lot of times it's just time. A lot of times it's time that's what's needed, and that consistency and that trust building. When, someone said a deeper problem like distrust, and that's, it's a fair thing. We often send people into communities and they're there for a little while and then they're gone. So I think, more question asking and assessing the situation is important.
Great observation.
Now,
Yes.
really quickly, that brings me back to the value of the community health worker within themselves. So the idea that they are this reflection, they're not sent in, they're not sent in from somewhere else into foreign territory. and their familiarity with that and their discomfort should be considered in that context, because it's not necessarily outsider awkwardness that they're feeling. This is something that should be, and in the best case scenario, is acknowledged, because again, their expertise is part of why that quote unquote lived experience is part of why they're there. It's the value that they bring to the position. So it should be considered in the analysis, as well as how the family is receiving it. Because remember, the outcome in this measure is the family's health behavior. So in that context, it's important to take all of this into consideration. I'm just kind of bringing the scenario to life and saying that these are the things that a good supervisor considers in the context, you know, this kind of, and it's partially also validating the kind of cultural um, expertise that the community health worker brings as. So, you know, whether that assessing that emotion is like invalid on the front end, I'm saying that's a mistake. So just kind of also understand where they are, where they're coming from, where the family is in terms of receiving this, because again, your job as the supervisor to help the CHW be effective. And then part of that is helping them to use these skills that they bring to the table to make these kind of good calls. So agree. I wouldn't, I'm not suggesting a pull them out directly either, but I am saying that that's a conversation. This kind of supervisory relationship with the CHW should be really back and forth. It's not really top down, because it's mutual, because that expertise that they bring, when they feel uncomfortable in a certain situation in terms of their own safety out there, that's a community call, and they're kind of better equipped to, you know, part of this is that they're better equipped to recognize and respond appropriately, not overreact, but also be able to respond and remove themselves and all of that. That's in terms of the safety. But I'm talking too much, but I just want to keep saying that these CHWs are valuable within themselves. So I want to be careful in saying that in the supervisory role, we need to continuously collaborate. You need their feedback, because what they're bringing to the table is important. And then you all together can assess whether or not they need to be pulled out, whether the family needs more time, all of these kinds of decisions. So I'm kind of encouraging all the, since this is a supervisory training, I'm encouraging the supervisors to be considerate of that and to take that value into consideration. That also helps with retention down the road.
Right.
And I think that goes back to the importance of having frequent meetings and providing coaching, because eventually that case, I'm pretty sure, could have been brought to the attention of the supervisor multiple times if they have been constant, supervision. And then techniques have been developed mutually, or the resources have been pulled in place to help the situation. So by the time, if sadly you need to make the decision that this is really, we have tried everything, and you decide that maybe it's best to actually remove that community health worker from that situation, is because you have used multiple tools and techniques and approaches to work with that particular case. But I think that human nature could be to the point that you get to the moment that there's nothing else you can do there. But of course, that's a discovery process. It's not going to be new if appropriate coaching and supervision has been provided week after week or month after month.
Right. Those were some really good observations. Certainly, we had a good dialogue surrounding that, and I'll just go back very briefly to understand and validating the feelings. And if I can just add this, another thing that I thought of was to arrange for some regular debriefing sessions with the community health workers, especially in a situation like this, allowing the CHW to have group discussions. I'm sure as supervisors, you all have team meetings, you have group
Mm.
meetings, you have peer meetings. So again, looking at those additional resources, brainstorming as experts, you have each other to bounce things off of. So again, so that the community health worker will not feel that she is left alone to solve a problem on her own. And a lot of this does fall back under what we call supportive supervision. And there are some instances where meeting with community health workers could be on a weekly basis. It could be on a bi-weekly basis. Again, all of that is determined by you and your community health worker. So again, good dialogue, good feedback. I just wanted to throw that out there because I'm not a community health worker and I'm still kind of treading new waters in the environment, but I saw that as a potential real issue. So I just kind of want to throw that out there for us to kind of chew on. So I thank you all for your participation. This last slide just talks about some resources. I do know that Annabelle did disseminate some job descriptions on the CDC e-learning module. There is a plethora of information. I mean, there is a wealth of information out there, from supervision to policies to job descriptions to competency. So certainly that is a site. RHI Hub has some of the same information. We will put these links on our on RHA's website as well. And then I was just going to say briefly, I wanted to let you know, most of you may be familiar with the community asset map, but there is a link to that as well. And with the asset map, it's an opportunity to list down within your communities the skills, the capacities, experiences of individuals that can contribute to strengthening local associations, sports clubs, schools, libraries. um, a lot of information can be put in an asset map, because what we want to do is help equip you as supervisors with as many and as much resources as possible. So again, that's just a list there for some resources, and I'll print this on a Word document and send it to you as well in a link so you'll have it. Again, I appreciate you for allowing me this opportunity. Is there anything else that needs to come before us that we would like to talk about? I think we're probably out of time.
Sorry, I muted myself.
That's okay.
We have 15 minutes for questions.
Okay.
That is really interesting. I didn't know that the hat hop was up and running. That's amazing. Um, does anybody has any questions, comments?
I'll just add that, I think by virtue of participating in this training over the course of a year, I know the goal is getting to certification, but I'm hoping that it's also an opportunity to build community among this kind of cohort of community health workers that are serving in small charitable clinic roles. So I think that's an important value that you've kind of, you're starting to build that community amongst each other, and they'll have each other to talk with as well. And, if there's anything that you all have as if you need help with anything, feel free to let us know. That asset mapping, I believe, is a deliverable item in your contract too. If I remember right, we've talked about that, and that's just making sure. And one of the reasons we were talking about that previously is that we know that some of you have already hired community health workers and maybe need a thing for them to do right away. Doing that asset map and just kind of mapping out who are the resources in our community that a community health worker can refer people to, or that, they may have services available, what have you. That's probably a good, really, really good first activity, is just taking an assessment of your community. What do we have? and what do we don't have. And then for those of you who haven't hired community health workers, I think that's something, too, that will come a little bit with this. So yeah, if you're working with Unite Us, it's making sure that you've got someone that knows how to navigate and look up those resources, maybe talking to some of your community partners to have that more in-depth understanding of what is available.
I've got one question while we're seeing if others have a question. If everybody could at least tell me if there was anything that you may have learned, or is there anything that you can take back to the office and implement, one or the other or both?
Hello, this is Tania Lascano, and I'm glad you guys are talking about how to better support community health workers. And I really appreciate it. Like, it confirmed to me that I need to spend more time with community health workers. And that's good, to get that confirmation as we get so many things to do. And then I have been wondering, am I using the time wisely? But I think long term, that is what it should happen. I'm originally from Ecuador, so I spent some years working in the mountains of my own country with indigenous community, indigenous people. They needed clean water. So I was part of this NGO bringing that educational piece to the project. And yeah, for me, like, all the situation is relational. And so that's why I have been like kind of debating, is this a good use of my time and their time? But I think this is key. Long term, it will be better. We can work as a team, because I've experienced just feeling lonely, and I think the coaching support, it has to be there. So thank you. I appreciated that, and I'm going to bring that piece also to our team. Thank you all.
Thank you.
Thank you,
Dr.
Dr. Burton.
Thank you. You're welcome. Okay. Let's see. Anybody else? Going once? Going twice? Well, again, I do want to thank you for your participation, your attention, and I look forward to continuing to build relationships and fostering collaborations with all of you as we continue to move forward and equip our community health workers with needs that they have or will have to ensure that we and they are successful in their roles. So if there is nothing else to be called to our attention, we're going to give you 10 minutes back. Okay.
The name of
Thank you.
All righty. Thank you all so much. Have a great rest of the day.
Thank you for
so
being
much.
with
Welcome.
us.
Okay. Take care. Bye-bye.
Bye.
Bye. Thank you again.
You're welcome.